So my name is Gerald Werner. I am the director of the cardiology within the medical department of Klinikum Darmstadt. We do about 1,000 PCIs, and among these 1,000 PCIs is a very high number of CTOs. Last year we did 300 CTO procedures here on site, mostly done by me, and supervised also some procedures by one of my colleagues. Well, CTOs are unforeseeable procedures. That's a problem. Often you can expect that this is a very complex procedure, but a regular CTO, even a 20 millimeter occlusion, can require a lot of complexity in the procedural approach. So our challenge is for each patient to provide him in one approach the revascularization of his occlusion. So we need fixed timetables, we need unlimited time for one procedure, no pressure by acute procedures that are necessary. So it's important, like in our setting, to have 2 cath labs at least. So the other cath lab is serving the acute coronary need when we have a CTO on this table. And the CTO requires, on average, just 2 hours, but it can last for 4 hours. And we need to dedicate this time to the patient and should not stop just because of logistic reasons. That's, I think, one of the first challenges if you set up a CTO program. Dedicate the time to the procedure and don't stop it. Beside the logistics and the time that you need to reserve for the procedure, the material expense is a challenge for the whole setup in the hospital. We have a limited DRG-related reimbursement, so we try to stay within this limited expense budget, and that's something that must be kept on mind. But it's we are convinced, the CTO operators, that we work for the benefit of the patient. And the relief of symptoms, which is immediate on the next day, when the patient gets up from night rest, he feels this difference, convinces us that we have to try to squeeze our material expenses within this budget. Aside from all these material expenses, we need specific technical devices in the lab. And I would say intravascular imaging, IVUS, is one of the major necessities if you build up a CTO program, because imaging, visualization within the occluded artery is very essential, and contrast is not helpful. Contrast filling in angio is not helpful in providing information that is really guiding you through the procedure. So we need these imaging modalities in the cath lab to do antegrade procedures, but also retrograde procedures. Last year, I think we did about 300 CTOs, as I said, and about half of them require IVUS. And during the procedure, or in cases like we did today, some cases where the diffuse atherosclerosis is required to assess the true artery size, and that is done with no other device than IVUS. Well, angiographic guidance is the main setup to plan the strategy, the procedural approach. But when you start the procedure, if you enter the proximal cap of the occlusion, you are always at a risk of already causing a dissection. The dissection is inherent technical part of the procedure. And once we are going outside of the lumen, we create subintimal space. If we continue giving contrast, we extend the space without getting information. So angiographic guidance is done by the contralateral injection, not by the antegrade injection. But the contralateral injection is just filling up to the distal end of the occlusion. So if we are in the body of the CTO and the progress of the wire manipulation is impeded by anatomical situations, we don't find the resolution by giving contrast. We need other imaging modalities, and that's where we need intravascular imaging. We could do OCT, but OCT is not practical. We need live information, forward, backward, assessing a certain segment. So that's where ultrasound as an imaging has its fixed place. It's a technical part and a psychological part, or a mindset. The operator who goes into a CTO procedure needs to be not under any logistic pressure, because, as we mentioned before, a CTO is not in its time requirements planned. You know, there are easy and there are more difficult CTOs. So you need to be under no pressure and going into the procedure. But it's important to have a pre-formed plan. What is my primary approach? What is the secondary, tertiary, or quaternary approach? So you need to have plan A, B, C, D in your mind set up, and you know at one point maybe in this there is no alternative plan to go ahead. To reach this level of planning, you need to have expertise, and nothing is in one CTO like the previous CTO. So it's not like doing a left main where we have a very, I think, structured approach with a bifurcation, but it's CTO is every day a new approach to a specific lesion, and you can only be successful from the experience that you have with other cases. So it's a clear, we found in our European CTO registry, a clear correlation between the number of procedures, so complexity of the procedure, and the procedural success. And that's also confirmed by other communities like in the United States, where you need a certain workload to achieve certain success. When you're an experienced operator, you need to invest your experience into the procedure. You need to gather all available information from the angio, from the collateral supply, from analyzing the entry into the occlusion. And what we also do is sometimes planning with a computer tomography. It's about 10% of our cases where we use this in addition, pre-planning and trying to analyze the path of the CTO. And during the procedure, whenever we get into a problem of ambiguity of the proximal cap during the procedure, we need to have imaging within the lesion. So I would think a good CTO operator is someone who applies IVUS, even with the financial restraints that we have, especially in Europe, I think, with wisdom and efficiency, and then IVUS reduces your procedural investment even, because you plan better, use the proper balloon, and it will achieve a better procedural result. IVUS has various roles during procedural steps of a CTO revascularization. Depends on which approach we can take in specific situations. If you have a straightforward lesion with an entry into the occlusion, well-defined distal artery, I wouldn't use IVUS. But as I said, in at least 50% of cases that we do, we see IVUS as an important, valuable tool. So in an antegrade approach, the problem we often face is, where is the cap? How can we define the cap if there is a side branch? So this is a clear situation where IVUS in the side branch will elucidate the structure of the cap, the position of the cap, and even help under life guidance to puncture the cap. Then we have the retrograde approach, where the basic problem is, after passing the collateral with a microcatheter, to connect antegrade and retrograde wires. And this connection can be easy, and in such a case we don't need IVUS. But if we get into a situation where, for example, we had today one case where we were close to the RCA ostium, where we could, if we go in subintimal space into the aorta, cause damage. Other situations are the left main. If we go from retrograde towards the left main, we need to have IVUS to clarify where is the wire position. So this is one thing to avoid complications. The other is, if we struggle making this connection, understand the wire position. Which wire is in which position? Where is the best place to make the connection? IVUS could reveal calcium. We cannot connect where calcium is blocking the distance between two wires, so we need to change the transition cell. And the third, and I think if we would really have thorough, well-planned studies, we would find out that optimizing a stent in a CTO is a situation in a coronary artery disease where the benefit is most evident. We had, especially the second case that we did today, we had a diffuse diseased artery which ends up with 4 millimeter from proximal to distal, which I would never dare to go up to that, even to the crux, without the safety information of where is the outer diameter of the vessel, how is the plaque distribution. So optimization and bigger vessels will have less restenosis. I think that is rather intuitive, will benefit the long-term outcome of the patient. The IVUS in an antegrade approach can either help puncture the proximal cap, so it can monitor where the puncture of the cap happened, and also we can follow with the IVUS into the passage of the wire when we are not quite sure where is the position. And if we have no retrograde option, sometimes the antegrade realization that you are in a subintimal space and you visualize the true lumen can help you get a second wire into the true lumen. So it's IVUS guided re-entry or entry. This is, of course, the highest level of CTO expertise, I think. That's not so widely used, it's not so frequently necessary. But I think the puncturing of the proximal cap and confirmation by IVUS is something that even beginners can manage and learn. Another field where IVUS guidance of wire manipulation can be helpful is the retrograde approach, where we position a wire antegradally, put the IVUS after pre-dilatation on this antegrade wire, and analyze the retrograde wire position. We sometimes find that transition zones where we want to make the connections are impossible, or that we are entering a side branch and the wire comes from a completely distal, different segment. So relative position of the IVUS in long CTO lesion helps understand the wire position of the distal wire. the retrograde wire. But one thing that one has to keep in mind, understanding IVUS in a CTO is a field that you have to learn. It looks different from just using IVUS in optimizing a left main stenting. So you have a lot of plaque, you have obstruction, you have a lot of echoes, and you need to find the echo that is really the wire. So it's a very difficile situation to learn. So it's a special training that the CTO operator needs to understand the IVUS. If we analyze the usage of IVUS worldwide, there are clear discrepancies. IVUS is used in almost 100% of procedures in Japan, even in Korea. IVUS is used less often, but recent registry showed in US that they use about 50%. In our European registry, we have a wide range of IVUS use from 5% to 50%. On average, it has increased over the past 4 or 5 years. Last year's analysis shows that it's about at 30%. So people find the value or appreciate the value of IVUS, and I'm convinced that they would use IVUS more often because it's not reimbursed. That's the simplest answer that you get. I make a long answer, but the simple answer is in Europe it's not reimbursed. It's on top. You have to cover it with your budget, and that is the simple answer, that we are very selective in using IVUS. I think that IVUS operators, also with experience with IVUS, interpreting IVUS images, understand the benefit they get from IVUS even more. And it's very clear that the complexity of cases has increased over the past years. With new techniques, new devices, we can tackle lesions that were beyond our imagination 10 years ago. More complex lesions provide more complex anatomy, and angio is limited in elucidating this anatomy. So IVUS is the logical device to use if you go into more complex lesions. So I think it's both experience with IVUS and appreciating the benefit, and increasing complexity of procedures that require additional information to conclude it successfully. The reason why IVUS is not fully accepted and also not reimbursed is certainly partly explained by the lack of compelling evidence that IVUS improves outcome. We have meta-analysis of IVUS outside of CTOs, that it's beneficial, and every IVUS operator who uses IVUS in a left main knows that he adds an extra 0.5 millimeters or 1 millimeter of diameter because of IVUS. In CTOs, the data are limited. We have Korean studies with small numbers. One of the studies showed that in IVUS use you had less stent thrombosis, as far as I recall, but very small numbers, actually not powered to really corroborate this finding. Other studies didn't find a difference. The IVUS trial, another trial using performed in complex PCIs, did not find a difference, but they didn't have many CTOs, 15% or so. So the problem is small trials and not enough power to really answer the question. Given the problems that we have in using IVUS in a CTO environment, we should have some incentive and some structured approach to say, okay, IVUS is helpful in such a situation. You should do it because it will benefit your procedure. It may shorten the procedural approach instead of kind of fishing in the muddy waters. So I was thinking of when do I use IVUS, in which situations, so in the antegrade, in the retrograde situation, and in the optimization of severely diseased vessels. And that was the setup in an antegrade situation where you have proximal cap ambiguity. That's the catchword. When where other algorithms suggest to go into a disruptive approach, to try to go subintimal, dissect, and try to re-enter, I think we should try every effort to stay within the anatomical structure of the artery, if it's possible. So IVUS helps us to understand where is our anatomic target, and that is why the first decision tree is proximal ambiguity. The second decision tree in the antegrade approach is, do I have another option, or do I need to, when I'm subintimal, try to get into true lumen with the help of the IVUS? That's what I said before, is a very high level quality of procedural technique. That's not everybody's field. But the first decision tree is relatively easy. In the retrograde approach, we use actually also in the European registry more often IVUS because it's a more complex situation. So the IVUS use, I remember in 2013, some time ago, but I had made an analysis. IVUS use at that time, on average, was 12%, but it was already 25% of retrograde procedures, so more than double. So in the retrograde complex anatomy, the IVUS is always helpful whenever you make no progress with connecting your antegrade and retrograde wire. If you struggle, you have a sequence of increasing the balloon size, but if you make no progress, you need to have understanding of the anatomy. And that is the main field where we will decide to use IVUS. And lastly, optimizing the stent in severely diffuse diseased arteries is more important for CTOs than for any other lesion, because if you have an occluded vessel, the distal vessel is supplied by collaterals, and the pressure these collaterals can provide is in the range of 30 to 40 millimeter mercury. And it's very logical that in such a low pressure environment, the arteries are underfilled. And even if you open the artery, the vessel is not increasing in size immediately, even giving nitro until the blood pressure is below zero. Doesn't help. So you need to understand the vessel size from proximal diameters and black load. And that is something that is aided by IVUS, I think. If we would have the financial means, that is why in Japan everybody can use IVUS, because each and every IVUS catheter is reimbursed on top of the procedure. If we would have not these restrictions, then I think IVUS is beneficial in 80% of the lesions. Yeah, not in simple JCTO score 0 lesions, 10 millimeter lesions. We have a proximal big artery and a distal big artery. Well, IVUS will not add anything, but in complex procedures, I would say in 80%, IVUS adds some benefit, and if it's only in the last stage of the procedure, in the stent position. For intravascular imaging, you have the option of OCT, of course, and there's no doubt that the resolution of OCT is superior to IVUS. But the downside is, in a CTO environment, you want to see the adventitia. You need to see the outer border of the vessel. And you need to also analyze, especially when we do antegrade wiring procedures, you need to move your IVUS forward, backward. So your catheter, your imaging catheter, you need life. OCT gives you a wonderful pullback, and it might be helpful if you put absorbs at the end. But during the procedure, you need life. IVUS is a device that you use in the beginning of the procedure, in the middle, at the end. So it should be a stable catheter. The imaging quality should be stable, and I think that electronic probes are superior to mechanical probes in this situation, because in the mechanical probe, and I worked for many years, I started with mechanical probes, you will have the air bubble obstruction of the image, and then you will have to work again getting the catheter air-free. So that's a hassle that you want to avoid in a CTO procedure, which is complex anyway. The use of IVUS within the CTO is a specific field that needs specific expertise. That's why a group of European, Japanese, and US operators were gathering their consensus and published recently in JAC a statement on the utility of IVUS is specific in this situation of a CTO, where we both addressed antegrade, retrograde procedures and also the value in IVUS stent optimization. I think that's a good resource.
Innovation and you. Philips.